After my video on migraines, a number of people asked about migraine in their children. So this video is dedicated to children, and here's what I plan to cover. Number one, why childhood migraine is often missed and why tummy aches might be a part of it. Then, the 6 tests that I check for every child whom I see with recurring headaches. Then, why finding a deficiency is just the beginning, and the question really is always, why is it there in the first place? And also, what to ask for at your GP appointment and what to do to get your GP on board with you. There are simple blood tests that I check on pretty much every child who comes to me with recurring headaches. Most of them have not had these tests done, and when we find something abnormal or suboptimal, and we do find those things much more often than you'd think, it changes the whole conversation. This video is about what's on that panel of tests and what to do when something comes back as abnormal. I'm Dr. Michael, I'm a family doctor. I've worked in surgery in the past, in emergency medicine, I was a ship's doctor along the way. And this channel is about thinking in medicine and not just the what, but the why. And with children especially, the why matters a lot. Children get migraines, a lot of children, and many parents are told, give them some paracetamol, keep the lights down, they'll grow out of it. Which is occasionally true, and it's frequently unhelpful. What I see in clinic is that migraines in children are a signal. The brain is telling us that it's not getting something that it needs, and a developing brain, which is running flat out, building connections, doing an enormous amount of work, has specific requirements. Certain vitamins and minerals aren't optional extras, they're working parts, and when they're low, the resultant symptom is often a headache. Now, before we get into the panel of tests, I want to mention something that parents often don't know about. Not all childhood migraines look like headaches. Some children get what's called abdominal migraines, recurring bouts of central abdominal pain, often with nausea, they look pale, lose their appetite, and sometimes they get a headache, and sometimes they don't. And it can go on for hours, and it can be frightening, and it's real, and it's frequently missed. It might be tempting in some situations to actually think that the child is feigning illness to avoid going to school, for example. And this, of course, needs to be thought about, as any stress can also cause abdominal pain in a child. But if your child keeps getting unexplained tummy aches that the GP cannot pin on anything obvious, and especially if there's a family history of migraine, this is worth raising. It's the same approach that applies, the same panel and the same thinking. Now, I'd genuinely like to know, has your child ever been told that their tummy aches or headaches were just stress or just school avoidance and it turned out to be something else? Put it in the comments, please. I do read them, and it helps other parents who are going to watch this who are in exactly the same position right now. And if you haven't already, please subscribe. It's how this channel is going to grow more and more, and I will really want to know how to direct which videos I'm going to make, videos like this one and many others. So here's what I look at, 6 different tests. Looking for iron and anemia as a first priority. Iron is probably the one I find most commonly abnormal. Children, especially girls once they hit puberty, but not only, run low on iron more than most people realize. And iron deficiency, even before it's reached the point of anemia, affects neurological function. It affects dopamine signaling in the brain. It impairs sleep architecture, and it can trigger headaches directly. I check ferritin specifically, and also serum iron, transferrin and transferrin saturation, and not just hemoglobin. A child can have a normal hemoglobin and still have ferritin in the boots. That's the stored iron, the reserve. It's a protein actually that's bound to iron, and when it's low, these things start going wrong before the blood count even changes. Most basic blood tests miss this because they don't include ferritin unless you ask for it. And of importance, ferritin can be normal or raised in an event that the child has an inflammatory problem going on at the same time. So even if they have a simple infection such as a cold or a cough with a fever, it's going to be raised and maybe raised for a while afterwards. So it's very important about the timing of this test, that it should be done when the child is well. Next, B12 and folate. B12 is essential for the myelin sheath, which is the insulating layer around the nerve fibers, and without enough of it, the nervous system starts misfiring, and headaches are a symptom that is recognized as a result of B12 deficiency. In children, low B12 is often from a dietary cause. There are children who are fussy eaters, children who are on plant-based diets without any supplementation, and occasionally because they're not absorbing B12 properly. And the absorption point really matters. If B12 is low and the diet looks adequate, that's a flag to investigate further. Celiac disease in particular can impair B12 absorption, as well as pernicious anemia, which is an autoimmune problem. We don't just replace the B12 and forget about why it was low in the first place. Now, B12 and folate work together in what's called the methylation cycle, which is a fundamental biochemical pathway that the brain relies on for making neurotransmitters, the chemicals that transmit signals between the neurons, and also for repairing DNA. And I always check them together. A child who's low on one is often low on the other, and the interaction really matters. Folate deficiency in children is again usually dietary. It's not due to not having enough green vegetables, or they're on a restricted diet, or for some other reason. But as with B12, if folate is low and the diet seems reasonable, think about absorption. Celiac again is the big one to rule out. Thyroid function. This one gets missed much more often than it should, and when it gets missed, children can literally go on for years without a diagnosis. Hypothyroidism, that means a thyroid that is underactive in children, can contribute to headaches. It's not the cause of the headaches usually, but it can definitely contribute and can definitely make things worse. And it's not something that people think of first, but it's definitely on the list and it's worth checking, especially if there's fatigue, weight changes, cold intolerance, or a family history of thyroid problems. Now, thyroid problems can be subtle in children. They can go undetected for a very long time if nobody looks. And in addition, if a child has hypothyroidism and they're being treated for this, then it's possible that they're being overtreated, and that in itself can cause headaches too, by increasing the amount of fluid that is produced around the brain. And if the thyroid test comes back abnormal, that requires a referral to a pediatric endocrinologist, and not something just to be managed by a GP, but the GP should absolutely be checking for it. Vitamin D. Vitamin D deficiency is extremely common, and no less so in children, particularly in the UK and in similar climates, particularly in children who spend more time indoors, and particularly in children with darker skin who produce less vitamin D through sunlight exposure. It's almost routine to find it low. Vitamin D has receptors throughout the brain. It modulates inflammatory pathways. It plays a role in pain sensitization, and there's reasonable evidence linking deficiency to increased headache frequency. And it's also one of the easiest things to fix. The question is always, again, why is it low? Is it just sun exposure and diet, or is there something else impairing absorption as well? Omega-3. Omega-3 fatty acids are a bit different from the others. It's not usually a standard blood test, though you can measure it. More often, there is a dietary history conversation that needs to be had. Are they eating oily fish, such as sardines, salmon, or herring, or mackerel? Probably not. And if they are children, do they get any omega-3 in the diet at all? And often the answer is very little. The reason why it matters, omega-3 fatty acids, specifically EPA and DHA, are very important for the function of the brain. EPA is important for inflammation, as in an anti-inflammatory, and DHA is involved because it's involved with the structure of the brain. And both of these are involved in how the brain manages pain signaling. It's low risk, cheap, and it's worth considering even without a blood test if the dietary history suggests deficiency, which it usually does. I've done videos about this and it's worth watching them. It's critically important to get a good source of omega-3, and it would really be ideal to measure the level and to repeat that same test months later and then maintain a good level, assuming that all things are going in the right direction. Finally, the why behind the numbers. Here's what I want to emphasize. Finding a deficiency is only step one. If a child has low iron, the question isn't just what iron supplement do we use? It's why is the iron low in the first place? Is it dietary? Is it absorption? Is there something else going on? Celiac disease is the one I think about the most. It's genuinely underdiagnosed in children, and it causes malabsorption of iron, B12, folate, and vitamin D simultaneously, and it can present with very little in the way of gut symptoms. Headaches, fatigue, and poor growth can be the main picture. And if we're finding multiple nutritional deficiencies in the same child, we're definitely checking for it. In addition, there's a bacteria called Helicobacter pylori, which can cause malabsorption and may not be causing any stomach symptoms other than that, though of course it can cause heartburn. This can be tested with basically a stool test or a breath test, depending on the child's abilities to perform a breath test. Now, other possibilities, depending on the pattern, include inflammatory bowel disease, pernicious anemia, which is rare in children, but it does exist, dietary restriction that's gone further than the parents realize, or in teenage girls with heavy periods, just blood loss that nobody's connected to the very low iron and possibly other low vitamins and minerals. The replenishment is usually straightforward once you know what you're dealing with. The investigation is the bit that requires some thinking. So what do you do with all of this? If your child is getting recurring headaches or migraines or recurring tummy aches that fit the abdominal migraine picture, and they've never had a blood test to check all of this, go back to your GP and ask for one. You can say, I'd like to check their full blood count with ferritin, B12, folate, vitamin D, TSH for thyroid, and free T4, please, and write it down. Most GPs will do it without much pushback. If ferritin isn't included, specifically ask for it. It often isn't on the default form. On a more basic level, ensure that your child's blood pressure has been checked too. We rarely check children's blood pressure unless it's in an emergency situation. So this is important not to be missed. And if something comes back abnormal, don't just accept a supplement prescription and leave. Ask, why is this low in the first place? What are we looking for as a cause? And is there anything else that we should be investigating? And if omega-3 doesn't appear on any panel, which it often won't, it's worth asking whether a fish oil supplement is appropriate. The evidence for it in childhood headache is reasonable and the risk is essentially zero, but talk to whoever manages your child's care and not just the internet. All blood tests and supplements mentioned should be discussed with the child's own GP or pediatrician. Dosing for children differs wildly from adults. Do not use adult supplement doses in children without medical guidance. Thyroid abnormalities require specialist referral. Celiac investigation should be done before trialing a gluten-free diet, as removing gluten actually normalises the antibody test, so it is unhelpful at that point. So what are the take-home messages? Childhood migraine is real and often under-investigated. Giving them paracetamol, Tylenol is not the end of the conversation. Abdominal migraine exists. If your child gets recurring unexplained tummy aches with no clear GI cause, especially with a family history of migraine, raise this specifically. The 6 tests worth checking: iron and ferritin, B12, folate, thyroid, vitamin D, and omega-3 status. Again, ferritin matters separately from haemoglobin. A normal blood count doesn't rule out iron deficiency. Ask for ferritin by name. If multiple deficiencies are present, think celiac or some other malabsorption problem. It presents in many ways and malabsorption is just one of them. And it needs to be investigated before going gluten-free and not after. Finding a deficiency is step 1. It's not the whole story. The question is always, why is it low in the first place? And that's the conversation you must have with your GP. Before you go, if you want to keep going on this topic, I'd point you to 2 videos on the right here. Worth watching both of them. This is The Accidental Doctor, a place where we try to make sense of uncommon sense medicine. If this was useful, please think about subscribing. It genuinely will help us to grow this together. And if you know a parent who's been going around in circles with a child's headaches and not getting anywhere, this might be worth passing on. Stay well. Ciao for now. See you soon.